Welcome to the Health Changers podcast presented by Cambia Health Solutions, where we share real stories of healthcare transformation from those experiencing it and those helping to make healthcare more personalized. I'm your host, Leslie. Making decisions about serious illness and end-of-life care are never easy, but those choices can be even more difficult for people facing the fear of discrimination. That's the case for many members of the LGBT population. According to the Healthy People Initiative from the U.S. Department of Health and Human Services, more than 3/4 of LGBT adults withhold their sexual orientation when seeking long-term care. Palliative care helps people living with serious illness and their family caregivers live well, and it works best when individuals and their care providers effectively communicate. It's especially critical for people making those important choices to have the freedom to be open about their lives and who they are. Our guest on this episode of Health Changers is dedicated to breaking down barriers for LGBT seniors. Carey Candrian is a 2018 Cambia Health Foundation Sojourns Scholar and a researcher at the University of Colorado. Carey, I would love to hear a little bit about your career path and how you got started in the work that you do.
Senior year, I took this class that was called Communication Theory with Stan Dietz, and it was really a class on like the science of communication, and really started talking about the effects that communication can have, the way we talk and listen to each other, the effects that this can have on other people. And even more, he really, with this class, started showing us how communication created these larger sort of systems and discourses of thoughts that influenced us. They showed us how to act, how we should behave, what we should say, what we shouldn't say. Things like, like a system, like what a family looks like, what marriage looks like, what a professional looks like, what having cancer looks like, what being on hospice looks like. And these systems, in doing so, he really showed how these systems become deeply ingrained in our vocabulary, the way we talk and listen, which means they really become hard to disrupt. And this class for me really unraveled everything, because I had never heard it, just completely blew my mind. And on that first day, this was the same teacher who he said, if you really want to make a difference in this world and really to change culture, you need to give people a new vocabulary. And this idea has really stayed with me so long, because personally, I was beginning to, it affected me, because I really saw that the way language and really interaction became constrained when people were not able to freely and openly express who they were.
Let me see if I understand this correctly, but you really dived into communication as a means of addressing systemic barriers, right? Like these systems that exist. But how do you use communication to break down those barriers? Am I correct understanding that correctly?
Yeah, exactly. Because I think if language is the reason why people are feeling shut out, it's going to be language that allows people to get back in and at least be able to find a way, whether to express themselves freely and openly, in the face of serious illness, when religion is part of the interaction, when sexual orientation, gender identity, race, ethnicity, age, all these things enter, they really can advantage and disadvantage people.
Tell me a little bit about how you got into the work with the LGBT community, and specifically with seniors.
Yes, so when I joined the School of Medicine, the faculty there, I started shadowing. I did this in college, was volunteering at hospice, but I really started shadowing admission nurses who would go out to patients in their homes when they were considering hospice or thinking about enrolling in hospice. And we were shadowing all over the state, but the one particular couple I had gone into, this was her second enrollment conversation, and she had another woman in the room with her, and the nurse was talking through sort of the scripts that they had, the forms that they had for hospice, and the traditional, are you married? Do you have kids? And who's your medical power of attorney? But and so the patient at the time was talking about the other woman in the room, how, she was her emergency contact. She had been living with her for 22 years, but she didn't say she was married, and the nurse, or even that she was, that she had a role beyond a friend. And the nurse sort of went through the paperwork and then left, and I ended up interviewing. So when she left, this other woman in the room was only known as the patient's friend, and she ended up enrolling in hospice. And I interviewed the couple afterwards, which I later found out was in fact a couple. And I think it really clicked to me, thinking of just the impact that communication and sort of these scripts that have become so ingrained, the consequences that they can have on the way people make decisions, and even later on their care. And so I really became committed to doing something about this. And I really felt like I could, coming back to the communication, really giving people a new vocabulary and allowing some space in the way that we do something as routine as talking about hospice.
Wow. I mean, what an interesting foray into this work. So, Carey, can you tell us a little bit more about some of the challenges or the disparities that this community faces, particularly when it comes to serious illness, end of life, hospice care? I'd love to just hear a little bit more about that.
The older LGBT population has been historically stigmatized, really their entire lives. And when I talk about the disparities, I think it's easy to put them in sort of three different buckets. The first one is economics. The second one is family and social support. And the third one is really the effects that this lifetime of stigma and discrimination has on their life. And then what happens when they do face serious illness or end of life. So for first economics, they, like the general population, they really do struggle, but statistically it's worse. They, one out of three older LGBT adults live at or below the federal poverty line for a number of reasons. In large part, they have been denied most of the lives of spousal benefits, of pensions, with gay marriage not being legalized until 2015. Many of them are more likely to live alone, which means they're really relying on a single income. And another huge factor is the lack of social and family support. They're 2 to 3 times less likely to be married. They're 3 to 4 times less likely to have kids, and therefore grandkids, and kind of the traditional caregiving structure I think we often assume and think about in healthcare. They're also more likely to be estranged, even rejected from their family, and they're even more likely to be isolated from their peers, which all this means is that they're aging with a really fragile and thin network of support. And then a huge underlying condition to all this, which is really my biggest interest, is the effects that this lifetime of stigma and discrimination has had on them. I mean, this generation grew up when really being gay was illegal. I mean, they could have gone to jail for holding hands in public. They lost their jobs. Many of them lost their jobs. They could have been kicked out of housing. Many of them were denied care because of who they were and because of who they loved. And even now, I mean, just in 29 states, you can still be legally fired from jobs and being denied care because you are LGBT. So I think that for me, this really, and I think why it affects the end of life so much, is that they've really been trained that in order to stay safe, they had to be quiet. They were trained from, way back when, really way before Stonewall in the 60s. I mean, it was unthinkable to be out. And so many of them have honed this habit of silence, really throughout their lives. And then it really becomes hard to break when yeah.
Oh, sorry. I just wanted to ask, what is the age range when you talk about LGBT seniors? What is their range of ages today?
When I say that, I'm talking about those who are in their 60s, their 70s, 80s, and 90s.
Okay. Yeah.
But great question. And so they've had this habit of silence that they've been, trained that really 75% go back into the closet when they do face a major health transition or enter an assisted living, which for me really becomes a communication issue because aside from the mistrust that they've had with the healthcare system, AARP did a recent study and showed that 40% of LGBT people who are in their 60s and 70s, 40% have not come out to their healthcare providers. And same study showed that 42% of transgender older adult patients have reported being denied or receiving inferior care. And so you have this like really unbelievable challenge where you have this generation that has been trained to stay quiet about who they are, so that they don't receive inferior care, and they have good reason to be scared. I mean, just with the 42%, but then also just in 2018, this hospice survey of over 800 hospice professionals reported that 42% of the staff had seen discriminatory behavior towards LGBT patients, from rolling eyes when couples were holding hands to actually disregard of patient wishes and even not including the partner in major decisions. And so you have this, it's really like this fundamental communication problem, because it does become an issue of, if they don't feel safe, they're not going to come out and disclose critical information. And if they're not disclosing critical information, the provider's operating with incomplete information, which I think makes any sort of medical situation challenging, but it really becomes magnified if you end up not disclosing who you are, or the most important person in your life, and later on, that person is excluded from care meetings. They're not able to advocate for you. They're not able to receive bereavement support. So it really becomes a complicated situation. And talking about those disparities, there's so many ways. There's so much work to be done in these areas. But this sort of the level of interaction is where I'm particularly focused on for this.
Tell me a little bit more about that, and what is the role that communication and that interaction play in improving the experience of patients with serious illness, and in addressing this disparity that they have often faced?
When you first, and I know that, sort of when you think just sort of broadly, like the biases we all carry and the assumptions we have really can color the way we speak and listen to each other, which then sort of can either constrain or enable a more meaningful conversation. But I think it's really clear with the story, and I know you've heard it before, but I think the story of Esther really is so poignant, because it really represents, I think, just how important communication really becomes. So she was, her partner had a rare form of leukemia and was in and out of the hospital. And as they were filling out paperwork, they had checked the box for married. But after they did that, they noticed that the nurse started behaving differently, spending less time in the room. And as Esther's partner became sicker, she asked Esther to stop checking the box for married, because it really became too risky for them, and they didn't want it to affect their care even more. And so,
oh wow,
yeah, and they had been together 33 years. And so at that point, Esther stopped checking the box for married, and then went forward as Kathy, her partner's emergency contact. And so when Kathy died, Esther was known to the hospital as Kathy's best friend, which meant really actually before she died, she was not considered sort of quote family, which meant she was excluded from care meetings. She wasn't allowed to be with Kathy when they were giving critical details about her condition and treatment plans. And then when she did die, as being known as a friend, she experienced tremendous disenfranchised grief for not having a loss, and even being not having a loss be acknowledged, and therefore not even being acknowledged as your partner. And it sort of spiraled out all these sort of clinical outcomes. But the root of the problem really was a communication issue. And I think if had maybe the question been, who matters to you? Who do you want next to you in the room to hold your hand? And then making sure that those biases and assumptions not necessarily go away, but are minimized, so that they can be with them and can be able to be with their partner when they are dying.
Carey, what has it meant to you to make an impact on this community, and what are some of the key takeaways from your work helping LGBT seniors? And I was also wondering if you could just define for us your use of the term LGBT.
LGBT, which means lesbian, gay, bisexual, and transgender, I use for a couple of reasons, primarily when working with LGBT seniors, who is my primary focus. The Q, which traditionally stands for queer, was really something that was incredibly derogatory. I mean, that was yelled at them when they were on the streets and really became a term that they rejected. And so they leave it off, and I leave it off. And then another reason is I just think that sometimes when it can get so long with the letters, the acronyms, that it really becomes like alphabet soup and can make talking about this that already can be uncomfortable even more uncomfortable. So I keep it short for those two reasons. But I do think what you did is such a great move too, because it is part of it too, that using what other folks, particularly in the community, use, I think is also a great way of just being in connection with the other person too, and showing respect and trust too.
That makes a lot of sense. Can you just share a couple things about what this work means to you?
I mean, what has it meant to me? I think it's meant everything, because as a social scientist with a background in communication, I knew I wasn't really going to be able to, affect sort of things happening from a medical perspective or on a clinical level. But as I was volunteering in hospice early on in graduate school and then later in the emergency department, I started to see just how much of what was happening and how much of sort of the disparities were not just happening on the clinical level, but also happening on the interaction and the non-clinical level. And at that point, I really became committed to this population because I felt like I could do something about it. And personally, I think to be part of the community too, I think meant a lot to me, that I did see, through my own experience, the effects of how language had shut me out for so many years, and how language was also the way I could get back in and express, what mattered and who mattered to me. And I think being able to work with a population that has had it so much harder than so many, I think, of the younger generations, and not that the stigma and the discrimination goes away, but when you really realize that this generation has, really fought the hardest to come out, it's meant everything to help them, just a little bit, hopefully make it a little bit easier for them so that they can, be able to say who they are and who matters to them when they really need it the most.
How has working with this community changed the way you look at healthcare?
I think the big thing that comes in working, and so much of my work has been more really on like a community level and more community based, is how constraining some of these scripts and even sort of systems of thinking, even the system of heterosexism within sort of the healthcare system can influence the LGBT community. So I think just how sort of these scripts and sort of our verbal habits and cues really sort of take on a life of their own. And I think it's so easy to forget how powerful these scripts are and how sort of they become unthinkable, but how paralyzing they can really be for people who don't fit those scripts or who don't fit those systems. And I think the innovation really comes in finding ways to break them so that people can give a different response, so people can feel that they can say who they are, can say who matters to them. But it's really hard to find that space when you enter and you're getting the same form and you're hearing the same questions, right. And you have one person, then you have a team person, and so it's this constant over and over, because you do face a choice as an LGBT person, particularly the older adults who've had this habit of silence, do you break the script and come out and really possibly get worse, treated worse? Or do you stay silent and not talk about the person that matters to you? And it really becomes a very real choice and a heck of a choice, because I think in normal situations it might be easier to come out, but when you are facing more of a medical crisis or something like the end of life, these things matter even more, become completely magnified, and the onus really becomes on the patient who has been trained to stay quiet. Yeah. And so I think the choice really becomes our best option is, instead of making them continue to face this heck of a choice after they've lived the life that they've had, is to break some of these scripts, some of our verbal habits, to really help overcome this lifetime of silence. And I had given a talk about a month ago, and someone asked me, aren't you setting the bar too low? And it bugged me in the moment, and I kept thinking about it and thinking, and I know that there's so much with policies and non-discrimination things that need to be done, but I don't think it's setting the bar too low, because I think we sometimes forget just how paralyzing these verbal habits and scripts and forms can be when you don't fit.
As a Cambia Health Foundation Sojourns Scholar, which is a 2-year grant program for leaders advancing palliative care, what was your project? Can you share a few things about your work as a Sojourns Scholar?
The project was a lot of what we've talked about was to develop guidelines for hospice admission nurses to talk with patients and those who care for them or their families about what hospice is, and then doing so in a way that can create space for people to also give an answer that's outside sort of the traditional script. And a big part, with these awards and with my award, has really been on the leadership and the advocacy, which I think has really become so, innovative about the awards. The relationship really between research as a form of leadership and also advocacy, which I think has been really, really important for me and my experience as a Cambia scholar.
That's wonderful. How will you broaden this work across? There's so many settings, obviously, for communication in the hospice world. How do you bring that across the country?
One area that I'm trying to move into, and I think how to really continue the reach sort of beyond community and beyond Colorado is, and for this podcast too, we focus a lot on how stigma and sort of this habit of silence affects LGBT patients sort of on like the micro level. Yeah. But when we think about the disparities that LGBT people face, we don't actually have any data, because we don't, like race and ethnicity, we don't routinely collect sexual orientation and gender identity information. In hospice and palliative care, we aren't collecting this information, which I think does a couple things. One, it continues to sort of denaturalize and denormalize talking about this and being able to collect this information. And then being able to, without this data, it makes it really hard to affect change on sort of a national level and even begin to see what is actually happening to LGBT patients in hospice, what's happening to their caregivers, what is their experience on palliative care. Without this data, we can't do much, and it does come back to if we're not asking these questions, we're certainly not gonna get it. But we do need to start asking about it. But I think the challenge again comes back a little bit to Esther too, that we can't just, which I think is the challenge with this community, I don't think to roll out and mandate hospices to collect this information without proper training and education is the biggest challenge. Because if you do, depending on where you live, or if you've been trained to stay quiet, if you come out, that could be complete ground. Your care could be affected. Coming back to the 40% and the 42%. So finding a way to do this, not just for the data, but to be able to, one, show that the recognition of other identities, but then also have this information affect the conversation, and then therefore tailor the conversation to the care, knowing that might need, questions might need to change, the conversation needs to change based on what you're learning. So I think the collection of SOGI for hospice and palliative care, I think really is a way to sort of begin to move this nationally, just to start talking about this in a more, having to be more common, and then being able to actually track the data, track outcomes, and then actually be able to meaningfully reduce the disparities once we know what's really going on.
Well, thank you so much, Carey. This was a wonderful conversation to have with you. Your work is enlightening and so important, and we just want to thank you so much for being on the podcast with us.
Thank you so much for having me, Leslie.
Carey Candrian is a 2018 Cambia Health Foundation Sojourns Scholar and a researcher at the University of Colorado. And that wraps up this episode of HealthChangers. You can find more information on all of our episodes at cambiahealth.com. You can also follow us on Twitter at Cambia, CAMBIA. You can now find HealthChangers on all of your favorite platforms. Just search for HealthChangers on Apple Podcasts, Spotify, and Google Play. Please subscribe and leave a review. Thank you for listening.